Because adversity is often the breeding ground for development, dive into Neurointerventional Stories, the uncensored interviews. Our guests, all leaders in the field of neurointervention, share the difficulties they face, the complications they have had to manage, and speak without filters on little discussed, sometimes controversial, or simply taboo subjects. Hi everyone, my name is Dr. Nanthiya Sujijantarat, and today I have an absolute pleasure of being with Professor Sirintara Pongpech, also known as Dr. Sirintara Pongpech. She is from Bangkok, Thailand. She's very well known in the community, and I'm very excited to be speaking with you today.
Thank you. I'm Dr. Sirintara Pongpech. Now I'm a full professor in Mahidol University, Bangkok, Thailand. I can start my career path around 1994. I have a chance to be trained in Bicêtre with Professor Pierre Lasjaunias. And then I came back home and become the pioneer in starting interventional neuroradiology in Mahidol University. Along with that time, I start to work with the international society. For example, the Australasian Federation of Interventional and Therapeutic Neuroradiology, followed by the WFITN, until I became the president of the both society. Sadly, become the first female president and probably the only one by now. So by being the pioneer, we definitely think about educational and training. So we start our national board in Interventional Neuroradiology Fellowship, that we recruit neuroradiologists, neurosurgeon, neurologists finally to become our fellow. That's probably extended to train also the Vietnamese young doctors, some of Malaysian doctors, and being kind of consultation to some of the Singaporean patients. And we are proud to be the center of international course, which combine the basic neurovascular anatomy, clinical and natural history of neurovascular disease. Actually start by the Professor Pierre Lasjaunias, Professor Carter Baruch, Professor Insop Choi, and other professors that come together and make this course in Thailand. So we've done that since the year 2000. Right now we are celebrating our 24th cycle, and we are happy to have probably more than 500 young neurointerventionalist doctors come for our course.
There's a lot to unpack there. You gave an amazing overview of what's going on in the region. So as a full disclosure, I am a Thai person myself, as we were talking earlier, and even I don't know a lot of the things that are going on in the region. There's really a lot of very amazing efforts, educationally, research-wise, that's going on in the region, and I'd love to highlight that a little bit more. I'd first start by asking, you have your hand in training so many young interventionalists that came out. And the Planet course is a course that I've known forever. It was one of those staples that as soon as someone knows that I'm Thai, they're like, do you know about Planet course? There's this amazing professor that's running it. So can you talk a little bit about how that came about, and what do you see is the optimal educational and training structure specific to that region, and how we can learn from that model?
So talking about Planet, it was a kind of international master course in neurovascular diseases that was done mostly under Professor Pierre Lasjaunias. The combination was done between Paris Sud University, Mahidol University, Toronto Western University, and the Boston team come together. That was year 2000. We believe that neurovascular anatomy is very important. It's the cheapest way to be safe and to know everything, since embryology goes up with variation of anatomy. Very important for your work. And then all the disease, if you know natural history, including the risk of symptomatic in each disease, because we believe that not all the aneurysm need to be treated, as well as not all the narrowing or stenosis must be treated in the same way. So that's why we want all the beginners to understand the possibility of having this as the very strong basic thing before you go to treat with a lot of tools. That is our belief. In year 2008, Professor Lasjaunias passed away, so we cannot continue the level of master course. So we make it a little bit shift into planet, which comes from Pierre Lasjaunias, PLA. And then NET is neurovascular educational team course. So we still keep the spirit from then and still teach twice a year, each time, full week, to make sure that you've known all what we want you to know.
Now, what is the current landscape of practitioners in Thailand? Are they mostly concentrated in the Bangkok region, or?
When we started to stem with the three main medical universities in Bangkok, it is Sirintara, Ramatipidi, myself, and Chulalongkorn. We are the three strongest ones. So each of us try to train. For example, we train Chiang Mai team, and we train the northeastern Khon Kaen team, while Sirintara train the nearby central Thailand as well as southern part. Chulalongkorn train another western or another part of the country. Each time we train people, I show myself to the director or the administrative team of each side that it's not just because you have a doctor that things can start up. So to have the 3M, which is the man. Man is not only doctor, full trained radiographers and nurse are very important. And then a machine for sure, that is material and machine. Materials, how you can have a stock of the essential catheters and embolic materials enough at least for the very urgent patient group. And then the last is the management, which is a patient recruitment, the reimbursement system. This is the three items that I always travel myself to each spot each year before I accept training to make sure that our trained fellow will go back and have the job to do. But when mechanical thrombectomy arrive, the work cannot be done by these full trained people. So we are now talking, the neurosurgeon are very active. So they come first, they said, we want a 1 year training instead of our 2 full year. So I would say that what you want to achieve from 1 year training. Life-threatening only, for example, the bad ruptured aneurysm or mechanical thrombectomy. And now we have a neurological society come to our society to ask whether they can train 6 months or 1 year dedicated for mechanical thrombectomy alone. So that is the way we expand our training following the situation that occurred in the world.
You mentioned, when the mechanical thrombectomy arrived, it really changed the landscape of how you train people, right? What are some of the challenges in terms of implementing such a revolutionary knowledge to the field in a country like ours?
So I think we have a strong pull in Bicêtre Neurological Institute. So when we train 2 or 3 of them, they help to negotiate a lot with the Ministry of Health. Because in Thailand, we divided the area of the health district. So this group of people will travel and will try to train the neurologists also just for mechanical thrombectomy. In Thailand, we are in the severe lacking of radio technician. It's a national problem now because we cannot graduate them enough. And then as soon as they graduate, they all fly to a private hospital, which earn 5 or 10 times more salary than becoming in the public center. When we start the 24 hours, we know that there are exact amount like 10% of nurse and radiographers come to quit their job from us. They were saying that even they got a little bit OT or extra time payment, but that would not help them to maintain their family or their work-life balance, and they don't want to be on call.
So let's shift gear a little bit and let's talk about research effort in the Southeast Asian region. I think that there have been some improvement as we can see that there's more randomized clinical trial that is coming from Asia in general. But I think this is a huge region that's full of untapped potential when it comes to research effort, especially for diseases that are specific to Asian population. Can you elaborate a little bit on that and where you think this will be in a few years?
I think the East Asian countries, they are significantly larger amount of neurointerventionalists in the country, as well as the financial support. So I have no doubt that region is booming. Right now, in Southeast Asia, I think we start to have some. We are now having a startup company coming and trying to gather all of us, looking at specific materials that can be used with our disease. For example, you know that detachable balloons will not be produced anymore because probably it wouldn't make money to the company because of the type of material. But the disease in the region, I think we include China, Southeast Asia, India, and probably South Africa, that this country will still have a lot of accident, trauma, that becoming a big hole fistula that no other material can be effective, fast, and cheap as detachable balloons. So either we try to produce ourselves, which I doubt for the quality. We have rubber, but to have know-how people to come and make it. So, for example, I have news from Vietnam group that we will have a setup company. We are trying to produce coils, larger coils in the very cheap price, because we're going to pack dense amount of coils to be equal to one detachable balloons to treat the same disease, which is probably still more expensive, but that is the best, because all the available coils now is not meant to plug in the high flow fistula. It's meant for aneurysm. In our region, we have the Cabanatuan as number one location. So again, we need a transvenous access and good, cheap fiber coils. In case we need to put 40 coils, can you imagine? Multiply by the price of the current available coils and the reimbursement from the government. Even this, we have one of the best universal health coverage, but all that is have a limitation of having that. In India, they have a lot of venous thrombotic disease compared to the rest because they have a specific factors in the body. I hope we can work together the entire Asia, because we still cannot conclude the guideline for ICAT. Even the lumen in the severe one, but if asymptomatic or responds very well with a regular antiplatelet, I have hard time to tell the patient that you should dilate it. So we are waiting for the guideline to come up.
That's fascinating. And when it comes to research effort, there's also more than just device development because of the sheer population and the sheer number that we have of these rare diseases alone. We actually should be the ones that publish the results of natural history.
I agree. And by seeing that, I go back to start with our medical student last 2 years who received a Prince Mahidol Award because she loved to do research. So she started to mapping all over Thailand the stroke center, the stroke incidents by the very scientific way, and come up with how many in each region can reach this tertiary care of mechanical thrombectomy, and what will be the main problems. And it starts with, for sure, the knowledge of the people that to know that this is stroke now. So she even fly to compare with the Canadian healthcare system in stroke. She spent almost a year with Canada team. So it can start with that kind of research. I think we should push more research into the educational part, the curriculum of medical student, the resident, as well as the fellowship.
So we are nearing the end of this podcast. Let me take you on a journey through time. If we can go back 10 to 15 years, what do you think you would do differently?
As a Buddhism, we always, at this age, I always say that things happen because there are reasons. There are things that drive you to be you today. So you know that I need to shift myself from a Royal Thai Air Force Hospital. Because when I first listened to Pierre Lasjaunias' lecture in Thailand, I came to him, I said, I want to be trained with you. I said, where are you coming from? I said, I'm proud. I come from the Royal Thai Air Force Hospital. And by that time, the angio machine was the best in the country. He said, no. Any type of army or air force or navy, they would not continuing supporting you for your career. They will support once. On the rest, they need to put the budget to others. So I need to quit from having a rank in the Royal Thai Air Force Hospital to become a staff in Mahidol University. One of the dean by that time, by chance becoming a friend of Professor Lasjaunias, and then he said, yeah, we're going to start a unit and I will be the pioneer. So there is nothing to regret by now. Probably the thing that I will try more during my first career is that I would try in the level of national training for radiographers and nurses. I would do more because I think it's none of my business, blah, blah, blah. But now it become the obstruction in many places. And maybe if I can we try already to work with the Ministry of Health in terms of reimbursement and stuff. So I hope that I can be the committee in this type of things.
I feel that we cannot understress the fact that you are a female pioneer in the time that it was really difficult to be a female pioneer. And knowing my country that I love, I know how hard it must be to be the first one. Can you talk a little bit about that?
Yes, in terms of medical student recruitment, we have fair amount of women. In my time, we are 10% versus 90% male. But now, right now, there are 50-50 or even 40-60 male-female or medical student. We have enough. But when we screen up to a neuroscience resident, they are significantly decreased female. So if we recruit from neurosurgeon, neuroradiologists, that could be a little bit more. Neurologists, there is fair amount. And then we pick up from that group, female neuroscience resident, to becoming interventional neurologists. We are less right now. Percentage are dropping. We've got a new fellow in these last 3 years, 0 female. I'm blaming the stroke. No, I'm joking. But, to have the 24 hours on call is not easy. So in the last AFITN meeting in Hong Kong, I analyzed the problem of recruitment is fine. We have no restriction, but they come up a little bit low. The maximum problem is during the first 5 years of working after training. How can we keep them? Because we found that 50% of our female training quit. So that's the period that we lost some of the female neurointerventionalists. This is all over Southeast Asia. And then if you pass the first 5 years, mostly you can stay. I'm glad that I have my well understood husband who let me travel. During my first 15 years, I traveled to work with this group of people to important conference a lot, and by that time, for sure, I have no money to bring my husband. Just now, I can have my husband travel with me, and because we don't have our own children, I have adopted daughter, which is already grown up, becoming a medical doctor for sure, and now we are fine.
And, just to provide regional perspective, because neurointerventionalists, neurosurgeon, all of these specialties in the Western world make a lot more money compared to the same doctors that are in our region. Truly, people who go into medicine, especially in Thailand, it is a job of sacrifice. It's a true job of sacrificing your time and everything. And so just so the listeners
almost
understand, it's almost that you're doing all of these things for free for your patients and to advance the field, truly. The second question, if we fast forward 15 to 20 years, how do you imagine the field will be?
I'm sure that environment or the disease, for example, ICAT will come up with something that, again, change our way of looking at how many doctors we have for the disease and blah, blah, blah. But you need to balance between the materials that coming up endlessly every year, the new devices versus the purpose of treatment that you need to teach For me, if you have the same clinical outcome to the patient in the same thing, I will still try to balance in teaching them. Now we have more neurologists coming to train. There are less neuroradiologists coming for fellowship. You know, if you sit at home with a tele type of MRI and CT and earn actually enough or more money than being interventional neuroradiologist in Thailand. So my idea is that you will have less and less neuroradiologists and you will have more and more neurosurgeon plus neurologists, which I don't know which one is rising up. We need to change the curriculum if they come as zero neuroradiologists. So they have less knowledge in image interpretation. So the curriculum design must be changed to add more months for them or more experience for them to test their knowledge. That's going to be the trend following what you have in disease versus fellowship people, recruitment. That's what I was thinking. Oh, I forgot to tell you that when we were talking with our friends around the country, in Vietnam, they have zero female neurointerventionalists. Zero.
Wow.
Why they have more than 200 male? I've heard that they have one started to do the mechanical thrombectomy only. So there are many parts in the world that percentage of female are quite low and it's hard to keep them.
Wow. That...
I hope we have a very interesting talk, and I hope you know, anybody who involved in what I try to say will come and look at us, especially research group.
Last two questions. If we now turn our attention to the training of neurointerventionalists coming out today, what do you think we're not doing or saying enough to them? What do you think should change about the way we educate?
I think learning process is not finishing in 1 or 2 or 3 years, because there are diseases. For example, I love spinal neurovascular disease is my favorite. And you know, when I came back in 1995, my first embolization is a spinal AVM. In your 1 or 2 years, in some training institute, you may not expose any, as well as pediatrics. So I think in each of the training, you need to be strict with your variety of disease approach, and then you write down the missing pocket, and then trying to mark to them that if you have a chance, there are centers that do receive more spinal case or more children case, and you take your time 1 or 2 months more to come back, have some experience. Or else you need to know that when you expose is a rare disease. The only way, you don't try to do it if you don't expose to it enough. Send it to the center and you will be there with the patient. It's your patient. And you refer to us, and I love to get A. You refer to me anytime, but you come. And I want you to know that what are we doing and what can you follow up this patient because of the, you know, they come from this province of the country. And number 2, they are part of OPD counseling. I really think this is very, very important in ethical part. We don't want to train your hands. We want to train your heart, which is ethical part. You need to see each patient and family and condition of the patient versus a family. How can you explain the same disease and the same prognosis to different type of family? And you need to accept your own risk. For sure, you can use your global statistic success rate and complications rate, but don't forget to put your own. The way to manage complications, early detection. Now your radiographer and nurse are a very important team because many times they are the one who detect your complications. And then I would say that you need to talk frankly as much as possible to the family and being able to follow up lifetime or until they becoming close to normal or death.
It's a very good point. We have discussed several difficult topics, and this has been an enlightening conversation personally for me. I hope the audience feel the same. Let's end on a positive note. what initiative, person, or advancement has most inspired or impressed you in the recent months, and why?
Wow, this is difficult to answer. What I would say is the way they use the new devices technically. So you can name people who do very, very fantastic technical usage of the new devices. So I think still Lohong here or Chapeau in German and Victor. While this is a group that I admire personally because I think they have a chance to, for sure, support by using the new devices. I'm impressed by the innovation here.
Well, Professor, thank you so much for your time. This has been an absolute delight.
More than welcome. See you next time.